Today we're going to be talking about seizures. We're going to be talking about what a seizure is, how you're going to diagnose it, and things you want to know in terms of treating it. I've dealt with a lot of seizures. So the way a seizure works, or what a seizure is, because there's multiple kinds. The main one we're going to be talking about is a grand mal seizure or a tonic-clonic seizure. What this is that the brain is meant to be controlled in the way that it talks, kind of like controlling the communication within the brain. But sometimes the brain overloads itself, where too many parts of the brain talk at the same time, kind of like in a conversation with 10 people and everyone spoke at the same time, you can't possibly follow the conversation, and then the brain kind of just cuts out. And that is the simplest form of what a seizure is. What this means is that the brain kind of stops functioning and everything goes a bit haywire. Tonic-clonic seizure, which is when someone generally just falls over and they shake back and forth, back and forth, back. The 4 phases of a tonic-clonic seizure is an aura. So an aura is generally something that someone might smell or taste or see, or whatever the case is. They'll have a feeling. So you might have seen like videos of someone dunking water over there. Like they'll take a bucket of ice and throw it over their head because they're like, I'm gonna get a seizure. Some people even lie down because then they know they won't fall over and hit their head. That's pretty clever in my opinion. Then you have the tonic and clonic. So tonic kind of just means like everything pulls tight, and clonic means everything relaxes. So they generally pull tight for quite a while, and then they have this back and forth shaking. So it's both arms, both legs, and the patient remains unconscious for the whole period of the seizure. Once the shaking stops, which it hopefully does, they will then lie there for a bit and be doing some really deep breathing, and then slowly but surely they should be able to wake up. And then they're in something called a post-ictal phase. That's kind of like how you feel when you wake up from a really deep sleep and you're like groggy, but they're confused, they don't know where they are, they don't know what happened. That is very normal for a tonic-clonic seizure. They wake up and they're very confused. That's just post-ictal. Hopefully, they don't have another seizure. They may just be like, you know what, that was weird, first time I've ever had that and it never happens again, or they're known to be patients who have seizures or they're on medications. A good thing to kind of try and rule out is why did they have the seizure, especially as paramedics or nurses and doctors, is why did they have the seizure? Is it because they stopped taking the medication? Is it because something else has changed in terms of how they've been treating their seizures? Are they taking drugs? Is there something else involved that's causing the seizure? Is there a head injury? Whatever the case. It's important to kind of work out why, because if someone has a history of seizures, they're on medication and now they stopped taking their medication and they've had a seizure, it's pretty straightforward what needs to happen. So there are many kinds of seizures. You can get partial seizures where someone's arm can shake and they generally just stay conscious in their arm or their leg, or they have a limb of their something moves, but they're still awake and they're still conscious. They can talk to you, look at you. That's not a tonic-clonic seizure because obviously they're awake. You also just get absent seizures, where someone just stops for a while and they go blank and then they suddenly start again, and it's just because they go absent and then they come back and they're not even aware. There's a Jacksonian seizure, there's all sorts of different kinds of seizures. What's really important is that as long as the patient is breathing, as long as they're maintaining their airway, as long as they're okay, that's what's important. So that's kind of why we give medications to stop seizures. So in the pre-hospital setting, we have benzodiazepines. You might have midazolam or diazepam or lorazepam. These are all different kinds of benzodiazepines that we use to stop seizures. They all kind of work slightly differently. Lorazepam is the one that is more specific for seizures. I will tell you a story at the end of this video about a patient who I had, and lorazepam was the tool of choice, and I'll explain why. So the way we treat seizures is we're going to give them one of these medications. These benzodiazepines will slow them down. In terms of slow them down, I say that because it slows everything in their brain down. So it slows their breathing, it lowers their blood pressures, it lowers their ability to control their airway. So whenever you're giving, especially if you're going to be giving midazolam, that's quite strong, 5 milligrams of midazolam, their breathing may stop, their blood pressure might drop, and they may just fall unconscious. That's important to note. The other thing about these medications is that they take time. If someone has a seizure and they phone for an ambulance, and you as a paramedic or someone get there and they're still having the seizure, it's been a very long seizure, because obviously it takes time for them to phone, for them to get the ambulance, for us to get to you. If they're continuing to seize, it's probably a status epilepticus, or someone who's going to continue to have seizures. So this is typically someone who has a continuous seizure without stopping, or someone who has a seizure a tonic-clonic seizure where they're shaking, they wake up, they're confused, and they have another seizure. And they wake up and they're confused and they have another seizure. So they never gain proper conscious, like they don't know where they are. So if you get to the scene and they've had a seizure and they're now slowly regaining consciousness and they're telling you where they are and they're getting better, they don't need medication to stop a seizure that they're not having. Because some people just have one seizure. I've been to many cases where a person just has a seizure and that's that. I believe that there's a relative chance that everyone may have a seizure at some point in their life and that they'll all go to a hospital to get it checked out and they'll find nothing wrong. It's just weird. The brain can just have a seizure and then never again. Weird how the brain works. The other thing to note is that you also get people that then fake seizures. That's difficult to tell, it's difficult to treat. The only thing that is important is that they're breathing, that they're maintaining their airway, and that they are well perfused. So they have a good blood pressure, they're perfusing well, there's really nothing to be concerned about as long as they're not currently seizing. A side note, which may or may not be that important, but if you give someone a paralytic, so if you're going to perform an RSI on someone who's having a seizure, you must remember that if we give them like rock or sucks to stop the seizure, it doesn't mean the brain has stopped seizing. They're physically stopped seizing, but internally, in terms of their brain can still continue to seize because it doesn't stop the seizure. It stops them from moving, but just because someone's not moving doesn't mean there's not stuff going on inside. It's important to know. So I hope I have covered all the bits, what it is, how do we treat it. It depends on which medication you're giving, so that's why I didn't mention specific doses, different drugs, different doses, different countries. And in terms of treatment is just give them oxygen, put them on their sides, get up an IV line. Remember now we can give like midazolam intranasally or intramuscularly, it's a bit slow intramuscularly. We can do other things besides putting up a line or putting up an IV line because that can be dangerous on a patient who's having a seizure. Remember, needles and sharps and needle stick injuries are no fun. And then in terms of that story that I promised you guys, so in working in South Africa, I was called to a little clinic in the middle of like a random area. I won't name any places, and I got there and the call was patient having continuous seizures, I will probably have to perform an RSI. That's the message I got. So I get there and there's this 14-year-old lady and she's having a partial seizure. They have given her the maximum dose of midazolam and they have given her the maximum dose of diazepam. So I think they were at about 15 or 20 milligrams of midazolam and 20 milligrams of diazepam, and she was still awake, conscious, and her arm was shaking. And the doctor was, well, maybe we need to RSI her. And I was just saying to her, she's having a partial seizure. Her arm is shaking. There's no need for us to do anything except take her to a hospital where they can do more scans. But I happen to have lorazepam. So I said to the nurse, let's just give lorazepam. Let's see what it does. Because we've given the midazolam, we've given the diazepam, just not the lorazepam. So we drew up 4 milligrams of lorazepam. I diluted it a bit because that makes it work better. Little golden trick there. And I just gave the lady lorazepam. And within 3 minutes, her partial seizure had stopped. Clearly demonstrated to me that lorazepam is the weapon of choice when dealing with seizures. So guys, if you did like this, or if you think you know people who would benefit from watching this, please share, hit like, subscribe. I appreciate it. I appreciate your time. Thanks for watching, and bye for now.